Hi, this is Dr. Perry Carpenter. Welcome to QME Training for Attorneys. I have a new video for you today, and I'd like to thank you for taking the time to join me on today's video. Today's video has to do with permanent impairments in and around the knee. And because knee injury conditions are so common in the industrial setting, I want to take a moment to go over some issues related to the anatomy of the knee and the physical examination of the knee that relate to the permanent impairment ratings that you're seeing for your clients. And one of the themes that I want to forward in this video is that qualified medical evaluating doctors frequently miss permanent impairments of the knee, and that has to do with our physical examination techniques. Many times these subtle knee laxity conditions meaning loosening of the ligament structures in and around the knee, are missed by our physical examination procedures because we're not careful enough and not thorough enough to detect these instabilities. And I want to draw your attention, just to establish the philosophy of this program, I want to draw your attention to table 1733 of the AMA guides. This is on page 546. In the second column of table 1733, the authors of the AMA guides give us a range of permanent impairment ratings for conditions in and around the knee. And I want you to notice that the highest permanent impairment listed in this column is 15% whole person. And after that, the next highest rating is 10% whole person impairment. And both of these ratings, these two highest ratings of 15% and 10%, are given for the coexisting laxities of either the medial or lateral collateral ligament with laxity of either the anterior or posterior cruciate ligaments. So what the authors of the AMA guides are telling us is that injuries to these ligaments frequently coexist. They frequently occur in tandem. These ligament structures frequently are injured together rather than in isolation. And the theme of today's program is that many times the coexisting laxity of the additional ligament is frequently missed. So what I want to do for you attorneys today is I want to give you some background on the anatomy of the conditions in and around the knee so that you understand, number one, what your client is experiencing, and then number two, what the evaluating doctor should be looking for in the evaluation of your client. And then once we establish the anatomy of the knee, I want to show you some of the physical examination maneuvers for the assessment of these coexisting laxity conditions, so that when you evaluate your QME reports, you can look and assess for these procedures. And you can make sure that these procedures have been done and the permanent impairments have been correctly identified. That is, if you're an applicant attorney. If you're a defense attorney, you're going to want to look at these examination maneuvers carefully and make sure that they actually are describing the condition for which the evaluating doctor is providing permanent impairment for. So this is going to be a fascinating program for attorneys, whether you're an applicant attorney or a defense attorney. You're going to get many valuable take-home tips, ideas, and suggestions from today's video. So I'm going to come back with you in just a moment, and we're going to begin section 1 of this program, where we review the internal anatomy of the knee with specific focus on the anterior and posterior cruciate ligaments. I'm back with you now, and I want to go over some anatomy review of the knee so that we're all on the same page and have our memories refreshed about what a busy place it is inside the knee. There's a lot of structures in a short period of time, and it seems that all of these structures are vulnerable to injury from activities that in some cases may seem inconsequential. And once we review the anatomy of the knee, you'll see that the knee, except for its stability in straight plane sagittal movements, is quite vulnerable to injury from laterally directed forces and also from rotationally directed forces, and that largely is a result of its anatomy. So let's review some of the anatomy of the knee. Well, let's draw a cross section here of the above down view of the right tibia. So as I look down at my right tibia, this is the perspective that we're looking. This is a superior view looking down on the superiormost surface of the tibia, known as the tibial plateau. Okay, so this is the tibial plateau. This is posterior, this is anterior, this is medial, this is lateral, and this would be the fibula bone here. The patella would be out here. So we're looking down on the right tibia. Now as you look down on the surface of the tibia, there's a couple of landmarks that present themselves. These are known as the intercondylyar eminences. Now this term requires some explanation. Sometimes the surfaces of the tibia are referred in various textbooks as the medial and lateral tibial condyles. Other authors refer to these as the medial and lateral tibial plateaus, so you'll see both terms in the reference literature. Well, the more current term, including the term used by the AMA guides, is that these are the tibial plateaus. But if you consider that these are also tibial condyles, these represent the eminences or the elevations on the tibial bone that are in between the condyles. And so that's one reason they're called the intercondylyar eminences. Another reason that they're called the intercondylyar eminences is because these eminences exactly fit in the intercondylar region of the femur bone. Remember, the femur bone has medial and lateral condyles, and then there's this crescent shape elevation or section of bone removed in between the condyles known as the intercondylar groove. Well, these intercondylar eminences here exactly articulate with the intercondylar groove of the femur. And the condyles of the femur then sit here in the medial tibial plateau, and the condyle, the lateral femoral condyle sits here on the lateral tibial plateau, leaving the intercondylar space open, leaving the intercondylar eminence space open. And we're going to see that there's a lot of structures that pass in the intercondylar space. Now, if we were to draw this as a side view, looking tangentially at the surface of the tibial plateau, we would see that these intercondylar eminences have elevation. They have elevation. Well, we can't draw elevation here on this two-dimensional diagram, but I want you to imagine that these represent elevations off of the surface of the tibia. And they provide a great depth for the femoral condyles. And so these intercondylar eminences prevent medial and lateral subluxation of the femur because movement is restricted by these intercondylar eminences. Quite interesting. And these intercondylar eminences form the medial and lateral borders of the articular cavity of the femoral condyle. So all of this is encased with synovial fluid. All of this is encased with synovial fluid, with some communication of the synovial fluid across the anterior aspect of the tibial bone. And of course, these surfaces, the inner surfaces of these intercondylar eminences and the superior surface of the tibial plateaus, those are lined with articular hyaline cartilage. Okay? So let's now draw in some of our important landmarks that we see. The first landmark that we want to draw in is back here on the posterior and slightly around the corner and then down the shaft of the tibia bone. We have a landmark here which represents the attachment point of the posterior cruciate ligament. Up towards the anterior aspect, we have another landmark here, which represents the attachment point of the anterior cruciate ligament. And what's interesting is that if we were to take a line and bisect the tibial plateau down the center, we see that the origin points of the posterior and anterior cruciate ligament, those are both slightly medially placed. Slightly medial to the medial side of midline placed. Okay? A couple other landmarks we have here. These are attachment points for the medial meniscus. And then here, we have attachment points for the lateral meniscus. So let's draw these menisci in. Here is the lateral meniscus. With its fibrous connections. Here is the medial meniscus. Okay? And then both the lateral and medial meniscus are attached to the tibial plateau, firmly adhered to the tibial plateau by the coronary ligaments. These are the coronary ligaments, and the coronary ligaments are nothing more than extensions of the fibrous articular capsule. The fibrous portion of the articular capsule becomes continuous with these coronary ligaments, which firmly attach the medial and lateral menisci down to the surface of the tibial plateau. Now, arising from here, we then have the posterior cruciate ligament. So let's draw that in, and let's use a contrasting color here. I hope you can see this. Posterior cruciate ligament ascends anteriorly and laterally to attach on the undersurface of the lateral femoral condyle. The lateral femoral condyle. It proceeds laterally. The anterior cruciate ligament proceeds superiorly, posteriorly, and laterally to attach on the posterior aspect of the lateral femoral condyle. They both attach laterally, and they both proceed laterally. They begin medially, and they both proceed laterally, and they proceed superiorly from the tibial plateau, progressing in opposite directions to attach on different parts of the femoral condyles, thereby anchoring the femoral condyles in place from moving either anteriorly or posteriorly. And then, just to complete our diagram here, I want to draw in another structure that's commonly associated, and this is the medial collateral ligament. The medial collateral ligament runs superior to inferior to attach below the tibial plateau. This is the medial collateral ligament. Okay, so there's our basic anatomy of the interior of the knee. Now, a couple of points that I want to make about this is, number one, notice how busy the area in between the intercondylar eminences is. The intercondylar area is quite busy. The intercondylar area is intra-articular, which means that these structures are within the articular capsule. However, they are not within the synovial lining of the knee joint. So this is not a synovial cavity in here, but it is contained within the articular capsule of the knee joint itself. So that's one point. Second point I want to make is that it's very busy in through here, and these structures, when they're injured, sometimes are injured in tandem or in multiples. Now, the typical injury that we see related to the knee joint, and that's described in our textbooks, describes a valgus force being delivered to the knee, a valgus force being delivered from lateral to medial to the knee. And this can result in 1, 2, or even as many as 3 structures being injured and damaged. And that is referred to in our textbooks as the unhappy triad. So with a laterally directed force to the knee, we get a medial gapping, a medial opening of the knee. Now, the first structure to resist medial gapping of the knee is the medial collateral ligament. Now, the medial collateral ligament, interestingly, is continuous with and confluent with the fibers of the coronary ligament. And so, in that sense, the medial collateral ligament is attached to the medial meniscus. They're continuous with each other. And so, as the medial knee starts to gap and the medial collateral ligament is tractioned and stretched, it pulls also on the fibers of the coronary ligament and can cause injury to the medial meniscus here as well. Injury right there. Now, if the force is sufficient, and if indeed, especially if there's some sort of a rotational component of the lower leg, injury can then come in to include either of the anterior or posterior cruciate ligaments. Now, of the two ligaments, the anterior cruciate ligament is the weaker of the two. It's much smaller in bulk and has many fewer ligament fibers, collagen fibers, than does the posterior cruciate ligament. Now, interestingly, is that the anterior cruciate ligament becomes taut, T-A-U-T, taut as the knee approaches full extension. And one of the functions of the anterior cruciate ligament is to prevent knee hyperextension. Hyperextension of the knee is resisted by the anterior cruciate ligament. Knee hyperflexion is resisted by the posterior cruciate ligament. So as the knee comes to full extension, the anterior cruciate ligament becomes taut and it reaches its full physiologic length. Well, it's at this point that the ligament is vulnerable to overstretch injury, especially from laterally directed forces, especially if there's a rotational component of the femur on the tibia or the tibia on the femur. Typically, it's a rotational force of the femur on the tibia because the foot is usually planted in an athlete. The foot is planted while the upper body is rotating around the tibia, and then there's a laterally directed force that disrupts the whole thing. So if we focus our attention now on the intercondylar area, what kind of injuries can we sustain in the intercondylar area? Well, we can sustain an injury to the anterior cruciate ligament, avulsing it from either its origin or from its insertion on the femoral condyle. We can suffer injury to the posterior cruciate ligament, either from its origin on the tibia to its insertion on the femoral condyle. We can suffer injury to the attachment points of the medial and lateral menisci, which I've redrawn in here for you so you can see those. These are all in the intercondylar area. We can suffer injury to the connective tissue fibers that connect the menisci to the attachment points on the tibial plateau. There's a lot of activity in here. We can also suffer injury here to the tibial eminentia. And when you take your diagnostic studies, especially your intercondylar tunnel view, that's a special view that allows direct visualization through the intercondylar tunnel, you're going to want to look for the presence of loose bodies or bone fracture fragments in the intercondylar space. These serve as attachment points for all of these structures. And so these are subject to torsional forces, shear forces, rotational forces, and avulsion forces. And so these tibial eminentia frequently suffer injury as well. So a lot of structures in there. For our next section on this video, now that we've reviewed the anatomy, what I want to do is I want to go through some physical examination maneuvers for the assessment of the cruciate ligaments. We're going to narrow our focus now down to the cruciate ligaments. And a couple key points before we get there. And that is, notice here, the anterior cruciate ligament attaches anteriorly on the tibial plateau and posteriorly on the lateral femoral condyle. The function of the anterior cruciate ligament is to prevent forward translation of the tibia on the femur. As the tibia moves forward, this band becomes taut and resists forward motion. The function of the posterior cruciate ligament is to prevent posterior displacement of the tibia on the femur. As the tibial plateau moves in the posterior direction, this cord becomes taut and resists posterior translation. Now, because of these central origin and insertion points, notice these small moment arms, these small area through which rotational forces are distributed. It actually represents a small percentage of the overall total surface area of the knee joint. So while these are excellent restraints for anterior and posterior motion, they're poor restraints to resist rotational movements. And so the knee is subject to frequent injury with rotational movements. And as such, it frequently results in either anterior medial rotary instability, anterior lateral rotary instability, posterior medially, and posterior lateral rotary instability. 4 different types of instability, depending upon which of these cruciate ligaments are injured. So we'll go over those and the other instability examination maneuvers in our next segment when we get to physical examination for the anterior and posterior cruciate ligaments.